and then start sharing there. So just click on this. There you go. And then now go to your PowerPoint.
Where is my PowerPoint? Should be there. But it's
You
on
have a
my
little.
file.
Yours is all. Well, so double click that.
There we go.
And then, yeah, your slideshow from the beginning. There we go. Okay, Stephanie, do you see this? Do you see what you need to see? And then her picture? So you go this way.
Oh, I see.
So that the camera can see up here. And they do better online if you point for things as opposed to, like, mine has a little infrared pointer. You can't see it very good. So if you're moving and pointing and everything.
This is the whole whiteboard behind you?
Yes.
And how do you get this up and down without closing down
You go. I just close it down. I just close down the room, and the lights will come up, and the board will go up.
It's okay.
And then, do you need to use it? Because there's a spot where it goes. Let's see. Where it goes to. No.
I'm not going to worry about it.
Up top. On the next break, I don't want it to disconnect something right now.
Yeah.
But if you did, if you just, I'm trying to think what would just make it white. If one of your lightest or brightest slides are like that, like this, how it's kind of white right here. You could raise this and you could write here and they would be able to see it. Does that make sense?
It's all good. We'll figure it out.
What are you wanting to write? Touch the top and it'll go up.
Yeah.
But if you want that to turn off and this go up, you can just stop the room. They don't, but I can bring you mine.
Doesn't matter. It's good. I'm learning.
Do you want me to bring you mine?
Yeah, that would be great.
Okay. You're welcome. All right, you guys. See you later. Listen up.
Okay, people! This is the first time I have taught. I'm extremely excited. Can you tell me?
Yes.
So, I have to tell you. Can I stand up?
No, are you going to?
Kind
Or are
of
you gonna stand?
back and forth.
Because they're looking at the screen, but if you want them to see you, you got to turn the computer. So
Oh, hi. Oh,
they do
I
want
gotta
to see
take
your
this
beautiful
off.
face.
Hi, look at, I had on lipstick. But just in case, I have it on my teeth. Okay, so we'll get started here in just a minute. This is pretty exciting. Isn't it? Isn't it? I can't see you guys. This is the oddest thing because I'm getting reflection off this glass in here. And so it's like, who's here? I don't know. All right, so here's the deal. Mark Richards, I think, just gave the last presentation for the test next week. So boom, there's a line drawn in the sand. Anything from today on for today's lectures will not be on next week's test. Thank goodness. Can you imagine
Wait,
if there
we
was
have
more?
two cardiac tests, one for children, one for adults.
Yes, yes. Well, when we say one for children, there's going to be EKGs on there. There's going to be pacemakers on there. There's going to be the cardiac assessment on there, blah, blah, blah. So just be aware that today's notes you can tuck away and dust them off for next week, because then I will lecture today, and then I will lecture Monday and Tuesday of next week. And Chantel will come in and do, I think she had 10 questions on that test. That's exam number 6.
No, I already found it. I just am
I'm
trying to
like,
figure
it's
out.
the last
previous
one.
And put it in a new one.
All right, so I cannot see the chat room. Stephanie is helping me. Let's all thank Stephanie. Thank you, Stephanie. But is somebody out there noting if we're recording or not? Are we recording?
Yes, you are.
Okay, perfect. All right, so everything from Mark's presentation on prior to that is going to be on next week's test. That's exam number 5. It's all Chantel. And then this lecture and Monday and Tuesday of next week is going to be exam number 6, which will be the next week. I think it's the 19th. No, it's not. It's after that. So it'd be the 26th. And Chantel has 10 on that. I have the lecture, you'll see it in the test blueprint when exam 6 comes up. Adult cardiac has 30 questions, and then vascular has 10 questions, and then hematologic has 10 questions, and then Chantel has 10 questions. So that's the breakdown for what this exam entails. Again, this will be exam number 6. But all of cardiac and everything you had last week and with Chantel will be on exam number 5. Okay. All right. That being said, let me just see if we can get this working here. I don't know. We're going to have to see. So can you see this all? How does that look? Looks good. Are you straight? Oh. All right, so we're talking about the heart again, but this time we're talking a little bit differently. Chantel talked about the assessment of the cardiac muscle, and you all remember that from your comprehensive health assessment. But today I'm going to address circulation more than anything else. So our first little, we got to read the objectives. Yeah, we got to read the objectives. So notice these objectives are not numerically in order. And that's because this is only addressing today. Yes.
Do you want to push the computer back and then turn it a little so they can see the whole screen?
Oh, okay. Back. This way. Does that work? Tell me.
A little bit more. Awesome.
Right there? Good. Kind of an odd thing, don't you think? Oh, well. Okay, so we're going to identify clinical manifestations of metabolic syndrome and how this places patients at risk for acute coronary syndrome. Classify characteristics of chest pain and their association with selective cardiac problems. Identify clinical manifestations and medical management of patients experiencing myocardial infarction and heart failure. Prioritize emergency nursing interventions for a patient experiencing an acute cardiac event. Identify clinical manifestations of activity intolerance associated with acute coronary syndromes and nursing measures to help patients conserve their energy. And identify principles a nurse can use to assist patients and families in coping with the changes associated with cardiac events. And now I need a drink. Okay, so let's talk about the circulatory system. Isn't this interesting? You know, the entire circulatory system of the heart has been mapped. So anytime that somebody comes in complaining of chest pains, and they have all these diagnostic tools that are used, the ECGs, the lab work, all that type of thing. They pretty much know what part and how much of the heart is being affected. So just in quick review, that's what they, where are you? Oh, there you are. So one thing in quick review is that there's how many chambers in the heart? 4, that's right. And so the inside of the heart is lined, and it's called the endocardium. Yeah. You only had this 3 years ago when you took human anatomy and physiology. But this is made of epithelial cells that are extremely smooth. And what is interesting about that material there that is different than maybe the lining of vessels and other parts of the body is that it is made to resist clotting. Yes, it is. Also, we have the coronary circulation, which provides circulation of oxygenated blood to the heart. Now, what is very interesting, I just love anatomy because it just makes sense. And so the freshest blood that you have coming out of the heart comes out what vessel? The aorta. And do you think it's a pretty significant size vessel?
Yeah, it is.
Oh, yes, it is. Oh, yeah, it is. So it's pretty big, and so it comes up off the heart and then immediately branches off. And guess what feeds the heart? Yes, it does. Those little branches that first come off the aorta feed the heart. Those are the coronary vessels. And why? Because the heart is so important. Isn't that just simple and yet beautiful? It is. And so here we have the right. Don't go back. Oh, better not be automatically going forward because it'll drive me crazy. How do we precede that? Okay, we'll go ahead and do this.
The arrow on the keyboard, maybe.
I don't know. I don't have, I don't. Anyway, we'll just keep moving. So the right coronary artery, find it on the picture because I don't dare touch the mouse because it may go forward. So the right coronary artery comes off the aorta, and then you have the left coronary artery. So here, right, left. But this is interesting about the left coronary artery. See how it comes down, but look at it. It goes down here, it bifurcates here, and goes here. And what is this area? The left ventricle. Do we think the left ventricle is important? Yeah, kind of. So what do you think happens when you have an embolism or a thrombus that comes up here and boom, blocks this artery?
MI.
You have, yes, a huge MI. And it's called, in fact, this artery right here, the left coronary artery, is called the widowmaker. Why? Because it totally sucks if you get a thrombus here, because all of this part of the heart is not going to get fed. It's the left ventricle and to some extent the left atria. But to the greater extent, this is not going to pump anymore. And so if it's not pumping, you're not going to get the circulation you need to perfuse the body. So it's very important. Yes, Mark.
What artery gets like clogged up the most when it comes to like the MIs and like strokes?
You know, it's very individual. It's very individual. But you got to remember here that there's the two main branches that come off the aorta, and so if either one gets affected, you're going to have problems. But this one is the dangerous one because this is what is pushing blood, oxygenated blood, out to the rest of the body. And if that ain't happening, you ain't happening. That's a fact, Jack. I had a friend whose husband got up one morning. He's been a smoker and a drinker for years. Not that drinking contributed. Maybe it did. I don't know. But he got up one Sabbath morning and decided to go trim some trees on his rental property. So he got up and went, and his wife went to church. It's what we all do in hopes to save our husbands. So anyway, so she went to church and he went to go trim this tree. And so while he was up there on the ladder, he started not feeling good. And he started not feeling so good that he decided he better go home. Now, Vaughn was a workaholic. And so for him to decide to go home, he must not have been feeling very good at all. So he got in his car to drive home. And then on the way home, he's going, this is getting bad. I am going to pull over and call an ambulance, which he did. And the ambulance got there within 2 minutes. And by the time the ambulance got there, he was too weak to unlock his electronic locks on his car. That's how fast it goes. That's how bad it goes. And so the ambulance got him to the hospital. What? I feel like I'm yelling. Is this too loud? You feel over?
I love it. Keep going.
Oh my gosh. So anyway, so they took him to the hospital. They called his wife. They said, you know, your husband's had this little heart attack. You might want to come to the emergency room. So she goes, and then she hears all the information. And he was taken upstairs immediately for a stent. And he's when I say he's fine, he was fine. He lived. Every time I talk to her on the phone, she tells me how many days it's been since he lived. And so it's been about 3 years now. But the thing is that when she was Googling it, she found out that the left coronary artery is considered the widowmaker because it goes so fast. If anything is clogged there, then your body is not going to survive without oxygenated blood. And that's how fast it goes. So when we're talking about circulation and occlusion and that type of thing, it's very important to recognize how emergent the situation is going to be and how critical the situation is. And one of the things I want you to notice as we go through this lecture is that the protocol for treating and running tests and providing care for somebody that walks into the emergency room takes a priority over everybody else. But the protocol has minutes within which you have a goal to get certain diagnostic tests accomplished so that you will know for sure whether or not this is a heart attack. We're talking minutes, and they were able to get the stent in Vaughn in less than 90 minutes from the onset of the event, and he survived. Now, is he at the same level of function he was prior to this? No, he is not. It's been a long, hard road for him. He went back to work within a couple of months, but still his level of functioning is not there, because his heart has been damaged and it's not able to function as normal. Now, you lucky people, you are going to get to see my drawing ability.
Hell yeah.
Yeah, it's not, oh yeah, it's hell yeah. Because you are going to see why I'm a teacher, not an artist. But there's things that we have to understand before we continue. So I'm going to draw over here. Maybe we need to see me a little bit more over here. Is this better? Okay. Just a minute. Got to go back. So let's minimize this, go back to this.
Yeah,
No offense to anyone else.
Oh. I would be fired so fast. Okay. Okay, let's see. Thank you. Share. It's coming. I know it's going to come. Because why? Because I have faith. Is it working for you? Because it ain't working for me. Let's try this again. We'll just keep it here for a minute. But you can't see all of me, can you? And that's so important, isn't it? Here. Share. Okay. Stop sharing. This has got to get to a point where we I'm going to try this one more time and then we're moving on. And too bad you guys at home are going to get a suckle experience because I don't know how to make this work. This.
They actually can see the presentation, it's us, but it's not.
Okay. All right. So anyway. Okay, we're just going to go there.
That's what I was saying, it's us, but it's not.
All right, never mind. Draw it home. You won't get that experience. I'll try and fix this at the break, people. I love technology. Okay, so let's talk about this for just a minute. Let me have this so we can see. All right, over here, people. Over here, over here, over here. This little hand here. This is the blood flow right here. But let's talk about the coronary blood flow and what happens or how blood gets oxygenated. And I know you just did this 5 minutes ago because why you did 20,000 pediatric anomalies that children can be born with, and it was all about blood flow. And so we start with the inferior vena cava and the superior vena cava coming in. Superior bringing the top half of the body, the inferior vena cava coming from the lower extremities. They're coming up and they're dumping all their deoxygenated blood into the right atria. And then the right atria goes down through the tricuspid valves into the right ventricle. And then the right ventricle pushes blood, deoxygenated blood, through the pulmonary arteries, which is the only place in the whole body that you have deoxygenated blood traveling in an artery. And it goes into the heart. And I will bring this up later just to show you, but the heart, the lungs, the blood goes into the lungs. And remember, I described the lungs to you. Can't you see me drawing all of this? It would be just phenomenal. So the lungs have this bronchial tree that has the trachea, then it comes down to the bronchioles, and then it goes into the bronchioles, and then it goes into the bronchioles, and then it goes into the alveoli. And it gets so far down into the alveoli that the alveoli are these grape-like clusters, but they're only one cell thick, and they have every single one of the gazillion, trizillion of them have a capillary surrounding them. And then it has a gas exchange, and then the blood goes into the venous capillary, or the venous vasculature of the pulmonary system, and goes back through the pulmonary veins into the left ventricle, and then down through the mitral valve into the left atria, through the mitral valve into the left ventricle, and it goes out the aorta. It's better when I draw it on the board. Anyway, so you have that system that is taking place here. And this flow is extremely important in the things that we're going to talk about today, because we will eventually talk about heart failure and how that happens, what causes that. So this flow, whenever you have a test question and it's not something that you're not really sure of, you're going to have to think about the flow. What is happening in the flow? Because the flow is going to be responsible for many of the symptoms that we talk about today, exactly where the problem is occurring. So, no, okay, we'll move that. There we go. So we're going to talk about coronary artery disease today. We're going to talk about acute coronary syndrome, and we're going to talk about heart failure. So these are the three cardiac problems that we will address today. And you'll realize that each of them has certain problems within that little category. So let's talk first about coronary artery disease. Now, if you'll remember, no, you won't remember. Why? Because you haven't had the lecture yet. That was last semester. Sorry. We did at one point, we are going to talk one point about atherosclerosis. What is that? Somebody tell me what that is. It's a narrowing of the arteries. Why? And what is plaque? Hyperlipidemia. That's where it begins. And what happens with hyperlipidemia? Before that. The fat starts permeating into the walls of the cardiovascular system. And so now you've got fat in the walls of the cardiac vascular system, namely the arteries. And so what happens with that when it's there, it starts to develop plaque, a hard surface over it. Now, the thing about it is how much does that little globule of fat going to affect the lumen? It all depends. If you have sustained hyperlipidemia for long periods of time, it's going to build and it's going to grow. And the lumen is going to get narrower. Shut up. I went to speech therapy as a child, you uncompassionate person. And I never did conquer the R's. I did not conquer my R's. I apologize for that. But it is. So, what was that word again? Narrower. It's getting more narrow. Anyway, so it's getting smaller and smaller. But has the volume of blood decreased? No. So now we're trying to push blood through the artery in a more narrow lumen, which does what to the pressure? Increases the pressure, exactly. Now let's talk about something else for a minute. What happens with hypertension? Here we go. So Mark had it over here. Sorry, not you, Mark. You, Mark. Mark Medina had it. And that is where you start, the vessels in the arterial system are much firmer. They're stronger than the vessels in the vascular system. But if you have sustained pressure over a period of time where it's not relieved, then the walls of the arterial system are going to begin to weaken. And if they weaken to a point, we learned about this with stroke, a little weakened area bleb, I want to call it a bleb, occurs where the wall has become so weakened that it starts to bulge out. And it thins, and it's quite a bit less strong than it was before. So now what we have here is high potential for an aneurysm, which doesn't always have to be in the brain. It can be somewhere else, but the brain, you're going to see the effects of it immediately. But it can burst. Has anybody ever seen an aortic aneurysm that has burst? You're talking minutes, the person will bleed out into their abdomen. And so it's a critical situation. So this is a huge thing. So what two factors or two disease processes do we have here in the United States that are the number one cause of coronary artery disease, where the coronary arteries of the heart are affected? Hyperlipidemia, which is another word for diabetes. Yeah. Well, I say, I know we're talking blood sugar, but if you talk hyperlipidemia, you're going to have high blood sugars in there as well. But what else? Hypertension. High blood pressure. Now, the thing with both of those issues is, do we feel any symptoms when that first starts to happen? No. It is asymptomatic, and you don't know that it's happening until something bad happens. So it's just things that you've got to understand, which are contributing factors, which are risk factors. So what happens with coronary artery disease, and what we're talking about with that, is that those coronary arteries have developed some kind of problem. The person's had hyperlipidemia, they have hypertension, maybe uncontrolled hypertension. And what happens is those blood vessels begin to narrow, and they have greater pressure there, and they can start to get blocked as well, or totally occluded. Now, what happens with coronary artery disease is that the vessels are starting to narrow, and the heart is not getting the oxygen it needs to meet the metabolic demands of the heart. So what happens here is the person develops chest pain. And another word for chest pain is angina pectoris. Now, angina, tomato, it doesn't matter how you say it. It just matters that you know what it means. So, angina pectoris is where there is obstructed blood flow through the coronary arteries to the heart muscle cells. And the most typical cause for that is going to be atherosclerosis. So anytime that your heart has these narrowed vessels in the coronary arteries, then there's workload put on the heart, then you're going to get a less and less blood to the heart muscle to meet its demands. So one thing about stable angina that you need to realize is that pretty much when we call it stable angina, it means that if we decrease the workload on the heart, then we are going to decrease the need of oxygen, and the blood flow can go back to meeting the metabolic demands of the heart. So the number one thing with stable angina is exertion. And what is the workload on the heart? If you have stable angina where your blood vessels are starting to narrow, then you're going to recognize that all of a sudden you're short of breath. All of a sudden, just walking across the room, you're going to be short of breath. This is not normal, but some people recognize that. Some people may notice it, but then they just blow it off. But anytime there is exertion put on that heart, where for somebody that has coronary artery disease, then we just have to reduce the exertion or the workload of the heart to get the heart to go back to meeting its metabolic needs. This does not mean that there is 60 or 70% occlusion of the vein at this point. This is where maybe they have 20 or 30% occlusion of the vein. I mean, not the vein, the artery, where the blood's flowing through. So we need to recognize that the pain is usually predictable, because we know that if we start overexerting ourselves, we're going to get chest pains. But we also know that it's predictable that if we stop the exertion, the pain will go away in a little bit. Now, I'm sure everybody has seen on TV that when somebody has chest pain, then automatically somebody standing around has nitroglycerin in their pocket and gives them some nitroglycerin. What does nitroglycerin do?
Yeah.
It dilates the coronary arteries, which is really important. Okay, so now we have the arteries opening up again. We get more blood flow through. We stop that activity, whatever we're doing. And within 15 to 20 minutes, we're back to normal. This is called stable angina. So recognize that it's predictable. It happens with exertion. Stopping the activity will stop the pain, and it's usually resolved with nitro. Okay? All right, so the next thing that we're going to look at is acute coronary syndrome. Now, when you're trying to learn this stuff, you'd think, okay, how am I going to differentiate coronary artery disease from acute coronary syndrome? Well, the fact that the matter is the word acute will give you the little clue. So with acute coronary syndrome, we have unstable angina. And this occurs when the arteries are 60 to 70% occluded. So the thing about this is that this really kind of puts the person at risk for a myocardial infarction at any time. It can happen at any time. Also, what is different here is that because the arteries are 60 to 70% occluded, then the heart is significantly compromised, and this can happen when the person is at rest. It's going to be a greater risk if they are very active, or what do you think when they go outside to shovel snow? Oh yeah, that's how my daughter-in-law's stepfather died. Went to shovel snow on the farm and had a heart condition. And he did have acute coronary syndrome, and he went out to shovel. He started shovel, and down he went. Because the cold makes those arteries constrict. And now the lumen, and he had unstable angina. And so it was two things against him. It was so it can happen at rest, or it can happen during activity. So you'll find that a lot of heart patients don't go out in the cold during hard winter months, and definitely we don't want them out there shoveling snow. So what happens with unstable angina is that if a person comes in having chest pain, let's say that they've had stable angina for periods, and they have their nitroglycerin, and they put their nitroglycerin under their tongue, and they wait 15 minutes, and they do it again. And they wait 15 minutes, and they do it again. It's not resolving. So the thing about it is that this person is now, nitro is not allowing the vessels to dilate enough to meet that metabolic demand of the heart. And so the person is now gone 30 minutes, maybe 45 minutes without appropriate oxygen to meet the demands of the heart. They're in trouble. Yeah.
So I was listening to YouTube video this morning with this guy, Nurse Mike.
Mm-hmm.
He was saying that if they have angina and you take nitro, and 5 minutes later they're still having angina, they're supposed to come in.
It's true. We're going to talk about that in just a minute, because there's different philosophies from different people. And again, this comes down to a minute thing. The treatment has to come within minutes. So we're going to talk about that. So I'm glad you brought that up. Glad you did. So basically, the thing about it is that with unstable angina, you have a greater frequency of events that happen. It can occur at rest, or it can occur with activity. Taking nitroglycerin does not help, and you're having a huge risk for having an MI. So there's one more thing that I want to talk to you about that is not necessarily in the groups that we're talking about here with coronary artery disease or acute coronary syndrome, and that's variant angina. And it can sometimes called vasospastic angina. Variant angina or vasospastic angina. And that is basically because of cocaine. Has anybody ever done cocaine?
Let me tell you.
This semester or?
What? Are we going to hear it?
Yeah, he did.
Okay, cocaine causes huge. Oh, sorry, they can't see me chewing eyes, so they don't know. But cocaine causes coronary arteries to constrict, and you know, you can see those arteries can affect, the constriction of those arteries can affect young or old people a lot. So this is why when you see people that have overdosed on cocaine, a lot of times it's going to affect the heart. But what does the blood from the heart feed? It feeds the brain. It feeds a lot of things. So sometimes Narcan's not going to always fix things. Okay, so it's just one thing that you have to be aware of. It has the pain that is associated with vasospastic angina is longer than is the pain that is associated with stable angina. And it occurs often at night. So the thing about it is that you don't have to overdose on the cocaine. It can happen later. This vasospastic or variant angina can happen later. Okay, so just an FYI. And it's like I said, it's not really associated typically with the disease process, because it is the disease process or the constriction of the vessels is secondary to the drug ingestion. Okay, so the thing about it there are, the next area that we're going to look at is myocardial infarction. And you'll see under there that I have a non-STEMI and a STEMI. What did you learn from Chantel's lecture what a non-STEMI and a STEMI is? Exactly. ST elevation of myocardial infarction that is associated with a heart attack. A non-STEMI is where you do not have an ST elevation in your ECG, but you're still having a heart attack. So the thing about it is that when we're talking about about acute coronary syndrome, we're talking about generally myocardial infarction, but it includes both the STEMI and the non-STEMI. However, the thing about it is that when a person comes into the hospital and they say, I have chest pain, then the protocol is in every emergency room, they get to go to the front of the line. Unfortunately, a lot of patients have learned that trick. They don't have to wait in the ER. I just don't feel good. I have pain in my chest. So they get taken to the back, they got their vital signs going, and they start getting some tests run. Meanwhile, somebody out in the emergency room having an ectopic pregnancy sits there for 7 hours.
Oh.
How do I know this? Because I lived it with my daughter. Yes. 7 hours she was sitting there. All right. So the thing about it is, all cases of patients that are formally diagnosed with unstable angina are always treated as if they are having the myocardial infarction. Because we don't know when it's going to happen. We can tell it's going to happen because of the pain. But when it's going to happen, we don't know. All right. So I go back. I don't know. Let's enlarge this. And let's move down here and try this. All right. So this is briefly, we're just going to look at this slide briefly because this is just pictures of how plaque builds up and the narrowing of the artery. I knew you couldn't picture that in your mind, so I don't know why I threw that in there. All right. So one thing that we have to realize, and one thing that we have to talk to our patients about, this is the way of nursing now and healthcare everywhere. For years and since the beginning of time, we have always in healthcare treated after the fact. And because it's gotten so flippin' expensive now, somebody brilliantly came up with the idea, let's treat preventative health. And so this is the way it's going, and this is what you all are going to be practicing and need to recognize, that the way of healthcare in the future is going to be preventative medicine. So when you have people that are at risk for coronary artery disease, then you have to kind of recognize that and do patient education. And it has to be effective patient education. Because how many times have I gone in and the doctor said you need to lose weight? I haven't yet. So has it been effective? No, it has not been effective. But it's there, you know, but it's just, you've got to learn to do this effectively. So this is a part that you need to recognize, that this is important information. It's not just we're throwing it out there so that you'll be aware. So the risk factors, and again, you have modifiable and you have non-modifiable. In fact, there's things that you can correct and things that you can't correct. But the focus of the education is going to be on what you can correct. And sometimes you have to take it to the nitpicking level of planning out, helping them plan, or getting them resources about nutrition, about exercise, about support groups, or teaching, give them referral to people that will walk them through the process of changing their lifestyle. So non-modifiable factors or things that a person can't change is age. Now, you're rarely going to see a brand newborn with high blood pressure, unless it's because of a heart anomaly. You're rarely going to see a newborn with hyperlipidemia. You're not going to see those things. So as the body, they have the cutest little hearts, and 90% of the time when a pediatric patient's heart fails, unless there's an anomaly, it's related to respiratory issues. But a new, fresh little heart in a little kid is just wonderful because it hasn't been exposed to all these terrible things. Although children obesity has become such a problem in the United States that children under the age of 12 have developed type 2 diabetes because of sedentary lifestyle and because of the crap that they eat while they're doing their video games. Yeah.
And these babies that come out like huge, right? Or if like the mom has diabetes and has obesity, like can they get fat buildup, or does their body, like as they're building in in the womb just know, hey, this isn't, I don't need this fat, so they just taste it without getting any test. Does that make sense? Because if mom has all the plaque built up and has hyperlipidemia, and that transfer over to baby.
You know what? I got to be frank with you. I don't know the answer to that. Natasha would probably know. I do not. But I do know that women that are pregnant women that are obese or have gestational diabetes do tend to have larger babies. And when I say larger, you're talking 10 to 12 pounds. They're really large babies. So, you know, I don't know. I honestly don't know why.
I mean, typically babies are losing quite a significant amount of weight, right, to
Mhm.
begin with, so are they just not concerned because it'll even itself out? Like, or,
I don't think that it's so much of a concern while the baby is in utero, but I do think it's a huge concern after the age of 3, what they take into their body. But again, about the in utero part, ask Natasha because I don't know. Didn't do OB. Oh no. All right, so age. Definitely, as a person gets older, they have started having they've had their diet for several years. Maybe they've started to smoke. They haven't started to smoke. Maybe they've had a sedentary lifestyle, whatever. There's been all this infusion into the person's body, and the body will react to what is infused to it accordingly. And so the older we get, we've had more exposure, and so the risk for developing heart disease is very high. You will find some seniors that have remained active into their 90s. A friend of mine they were my parents' best friends, is 94, and he just went hang gliding. Who does that? I don't know. But the thing about it is, he's been very active. Of course, he's the last one living too. All his friends and his spouses already passed away. But it's who?
Natasha,
Oh.
she's walking right now.
Did she know to come in? No, she did. All right, gender. Women have an increased risk for developing coronary artery disease after menopause. But somehow when he and she get into their 70s, the risk for developing unstable or stable angina is about the same. We know that African Americans have a significantly higher risk for atherosclerosis. We know that genetics is critical. And I got to tell you this is so true. There are people that smoke cigars since they're 20 and now they're in their 80s and 90s and they don't have heart problems. Or there aren't any symptoms of heart problems. So genetics plays a huge role in it. Family history is critical. But there are things that can be changed. These are modifiable risk factors. So if you were to see modifiable versus non-modifiable somewhere in the future, you got to recognize that is you're looking at options of things that can be changed versus things that cannot be changed. So modifiable risk factors would be an elevated serum cholesterol, tobacco use, sedentary lifestyle, hypertension, diabetes, obesity, excessive alcohol use, and stress. So what is the deal with alcohol? What the heck? What is the problem with alcohol? It does increase blood pressure, and it raises triglycerides. There you go. I know. Now, one of the things that is a huge factor, and maybe you have not heard this before, we did have this in one of the neuro lecture, and that is metabolic syndrome. And metabolic syndrome, I have to tell you, is very, very interesting, and I have it. And you decide why, okay? Oh my gosh. We'll talk about this and then we'll go to a break. I just looked up to see the break, the time. Okay, so this is a condition. It's just a multitude of conditions, and there's 5 characteristics to it. And if you have 3 or more characteristics, then you're considered to have metabolic syndrome. Okay. But the reason why we're talking about metabolic syndrome here is that because if you have this syndrome, you are at greater risk for high blood pressure, high blood sugar, excess body fat, and high or hyperlipidemia, cholesterol and triglycerides, which are precursors to what? Cardiovascular disease, acute coronary syndrome, coronary artery disease. Yeah. Yes, that puts the person, if you have metabolic syndrome, it puts the person at risk for increased blood pressure, high blood sugar, excess body fat around the waist, and abnormal cholesterol and triglycerides. So here are the conditions. I'm sure everybody can read those. So here we go. Remember, I have metabolic syndrome. So try and picture this. Does she have that? Does she not have it? So the first one is a large waist size. So for men, if you're greater than 40 inches around the waist, then that is the criteria that we're looking for. For women, it's greater than 35 inches. Okay, increased fasting triglycerides. So if you have a level that is greater than or equal to 150 milligrams per deciliter, or if you are on some kind of anti-cholesterol drug. Decreased blood, HDL. So if you're a man, if you have less than 40 milligrams per deciliter. For women, if you have less than 50, or you are taking an anti-cholesterol drug. This is all written down, so you don't need to be copying it. It's on the slide. If you have hypertension, so are you ready for this, people? If you have hypertension or a blood pressure of greater than, are you ready? Are you ready? 130 over 85. It's insane. And then if you have an increased blood sugar greater than or equal to 100 milligrams per deciliter, or if you are taking an anti-diabetic drug. 100 isn't that high, people. I'm just telling you, it's not that high.
None of this criteria is very extreme, right?
Well, okay, repeat that.
None of this criteria that you would meet, no 5 of those are super extreme. It's not like.
No, it's not. Exactly. So, and this is what's disconcerting about metabolic syndrome, is that you only have to have 3 of the 5 to have metabolic syndrome. And as Stephanie said, these aren't numbers off the chart. In fact, some of these numbers are within the normal range that people have in the United States. But if you have 3 or more, you're at risk for having this cardiovascular disease called coronary artery disease or acute coronary syndrome. Yes.
On the blood glucose, does that apply to like medical diabetics if your blood sugar is so high?
Okay, so, and that's a good question. And the thing about it is it doesn't really matter. It doesn't really matter. So if it gets above that, the damage is still being done that can result in the coronary artery disease. So now that we've got kind of a broad overview, let's take a break and come back at 10:30, and we will, I guess, continue. Ian once had a potluck yesterday. Maybe we can go with refreshments that were left over. I don't know. Anyway, come back in 10 minutes, 10:30. Be there, be square. Okay, we're back. Lucky you. Okay, one of the things that I wanted to mention was that when you start getting your blood sugars up, remember the top 2 disease processes that lead to cardiovascular disease in the United States is diabetes and hypertension. So there is a pre-diabetic stage. Does anybody know what pre-diabetes is? It's hyperglycemia, but it doesn't meet the criteria for treatment. So when you're looking at pre-diabetes, the normal range is 60 to 100, and then pre-diabetes is usually 100 to 125. And then at 126, a glucose level of 126, then pretty much you are diagnosed with diabetes. However, they don't start treating you really until you reach 150, a fasting blood glucose of 150. Same with A1C. They're not going to treat you. The normal range for glucose for A1C is 4 to 6, but they really don't start treating that until you're greater than 7. So you do have a little bit of leeway here before they start giving you the drugs that will help control these levels in your body. But again, they're shooting for lifestyle change. That is preventative health care, where you are looking for a change in behavior to maintain a healthy or a health status, that you don't get worse. Again, these are things that will give you advanced knowledge. The metabolic syndrome will give you an advanced knowledge that if the person has not already been diagnosed with cardiovascular disease, they will develop signs and symptoms that will lead to that diagnosis. So let's start with the chronic stable angina pectoris a little bit. We talked earlier that angina is basically chest discomfort. Notice that I don't say pain. And this is what was so interesting, that when I was reading about this topic, that when they go in, when a person that has chest pain goes into the emergency room and are describing how they're feeling, they're doing their Caldera, is they do not mention the word pain. It's a tightness. It's a heaviness. It feels like an elephant sitting on my chest. There's pressure here. There's radiation there, but they don't use the word pain, which I thought was very, very interesting. And this occurs when you have moderate or have increased your exertion state. You have put a greater workload on the heart. It usually will subside with rest, and it usually lasts 15 minutes or less. Oh, shoot. All right. All right. Now, with chronic stable angina, we want to talk about what are some of the signs and symptoms or clinical manifestations. So first of all, I told you that there is this discomfort here. A lot of people will say that it radiates to the left arm, but that is not always the case. It doesn't always radiate. Each person is going to be very individualized in their description of what is happening with their body. Again, with stable angina, we are going to know, you're going to ask the person what triggered the event. Remember, with Caldera, you're saying the onset. What was the onset? What were you doing when this happened? So we usually know that this stable angina begins with this exertion, that there has been a greater workload on the heart. It usually is relieved with nitroglycerin, and the pain or the discomfort will subside within 15 minutes. There's usually no associated signs or symptoms with that. You know, there isn't the profuse sweating, there isn't the nausea and vomiting that may be associated with acute coronary syndrome. But what you have to do with a person that has chronic stable angina is tell them to stop what they're doing and lay down. Take their nitroglycerin. Now notice here, oh, don't you love this? Okay, I'm hoping that when you pull up the PowerPoint, you don't have this distortion that you get with the big blue button. But here it says two different things. And these are the orders that are given with nitroglycerin when a person is being educated on how to treat this chest discomfort when it comes on is dependent on the doctor's preference. So it can be one of two things. So the first thing is that if you take a sublingual nitroglycerin and wait 5 minutes, and if the pain doesn't go away, then take another one, wait 5 minutes, and then if the pain doesn't go away, take a third one, and then go to the hospital. Or in the blue, it talks about the doctor giving orders that after taking one nitroglycerin and waiting 5 minutes and nothing's happening, then go to the hospital. Now, that being said, those are what are prescribed orders, but I hope that you recognize today after the lecture that once is good for me. I'm not waiting because we're talking a minute thing here, that some interventions have to be accomplished within a certain time frame for treatment to be effective. Now, one thing about a chronic angina, a stable angina, is this feeling of heaviness on the chest. You just can't get comfortable. No matter what you do. You try taking a whirlpool bath, you try taking warm shower, you're trying to do all this stuff to feel better, and nothing makes it feel better. Some people describe it as a vice-like crushing feeling. And again, with exertion, it comes on, but it is relieved by rest and taking nitroglycerin. People at home, sorry, I'm just reading, make sure I've said anything about it, everything about it that I want to say. Okay. Just recognize that, again, the prescription is dependent on the doctor's order, whether you wait to go to the hospital until taking 3 nitro tabs or taking 1 nitro tab and waiting 5 minutes. If there's no relief, then go to the emergency room. The people that have this will be educated that their diet should be one of low sodium, low fat, and low cholesterol. Now, we said, this is it sounds contradictory here, but in fact it's not. And that is because when a person has an event where they have chest discomfort, we say stop the activity and rest. But one of the educating factors that we will be giving to a person when they're stable and there is no chest discomfort is that they need to exercise. But they need to progress very slowly. So if this is happening and starting to occur more frequently, then we need to, if they haven't started anything, then don't have them walk 5 miles a day. You educate them by having them walk to the end of the driveway and back. And then after 2 or 3 days, we have them walk from the driveway down to the neighbor's house and back. We don't have them overexerting themselves, but what we're trying to do here is recondition the body, recondition the heart, and make that muscle stronger. And then we will also talk to them about statins, which are lowering their cholesterol levels and triglycerol levels in the body. Okay, so here, let me see if I have one here. I don't know if I have one here or not. No, we don't. Okay. I'm just moving past all that. It was just a case study. I'm not going to do it. All right, let's move on to acute coronary syndrome. Again, we're talking about unstable angina and myocardial infarction. Many times, people that have come in and have unstable angina, they will be treated as if they are having a heart attack because it's so similar. We're not going to know if they're having either or until we do some diagnostic testing on them. So the symptoms, the signs and symptoms are going to be very similar. But again, there's going to be some things showing that the heart muscle itself has actually become damaged that are revealed when we're doing that testing, that diagnostic testing. So outwardly, we really don't know the difference. So with unstable angina here, this is chest discomfort that occurs whether the person is at rest or they're actively doing something. And if they have been previously diagnosed with chronic stable angina and they get up and they take their nitroglycerin and it doesn't work, it may work a little bit, but it doesn't take that discomfort away. It's still there. And again, this is when the artery has narrowed by 60 to 70% in the lumen. And so they can have a myocardial infarction at any time. Now with a myocardial infarction, this is when the tissue itself of the cardiac muscle is when it is severely deprived of oxygen and damage begins to occur, injury begins to occur. Does this mean that they are going to have, there's going to be death of the tissue? Not necessarily. But it does mean there's going to be injury to the muscle itself. Now, when there's death of the muscle itself, then it becomes a cardiac arrest. We defined myocardial infarction earlier as being a STEMI or a non-STEMI. ST elevation in the ECG or no ST elevation in the ECG. Which one do you think is more likely to be fatal or lethal? It's the STEMI. It's with the ST elevation. We're going to talk about that in a little bit. I wrote this in yesterday, so it must be important. Let me read it, because I don't remember what it said. The terms STEMI and non-STEMI are most correctly used with patients with clinical characteristics compatible with myocardial ischemia with increased troponin levels. So here's the deal in the diagnostic testing that we're going to begin discussing in just a minute here. And that is that you have these signs and symptoms, and whether you have injury is determined by the troponin levels, or a lab value, or LUV. That's a cardiac marker. We call it a cardiac marker in the blood. So what does that mean? That means that it's going to be critical that we take lab work, isn't it? For somebody that comes in with chest discomfort. Now I have here a fabulous chart, which I'm sure you'll appreciate. It talks about the signs and symptoms of chronic angina, and then it compares unstable angina and myocardial infarction with the two. But notice that here, some of them are pretty simple to remember, but you're going to see that with the unstable angina and with the myocardial infarction, there are a lot more associated signs and symptoms. So there's other things that are going to be accompanying the event, signs and symptoms. And we'll recognize if they have those, that more than likely, of course, as a nurse, you realize you're seeing things, you're making judgments immediately, and most of your interventions are directed towards that judgment you have. That's what the NCLEX is all about. It's not about testing your knowledge. That would be knowledge level questions where you're just regurgitating information back. The NCLEX is judging your judgment and what you're going to do when you see something. And that's basically what you're going to do. When the person comes in, they're complaining of chest pain, they're moved up to the front of the line, you're getting their signs, their vital signs. You're going to be watching, you're going to be looking, you're going to be observing these things. When you see the associated signs, you're going to immediately go to the worst case scenario. Then creeping, gently progressing in your diagnostic tests, you're going to go to all the tests first if you see some of these signs and symptoms. So you notice that with a myocardial infarction or the unstable angina, you have nausea and vomiting, you have diaphoresis, you have a increased work of breathing or a shortness of breath. There is this feeling of impending doom. You know something's wrong. This is not normal. You can't fix this by laying down what you've tried. You've tried taking your nitroglycerin. It ain't working. You know that you're in trouble. Fatigue, epigastric distress, hypertension, and disorientation sometimes occurs. But one of the big things that is going on here is the fatigue that is occurring because of the lack of oxygen that is being supplied to the heart. And if it's not being supplied to the heart is not able to function, to contract and get the blood out of it as it should. It's not going to have the force there. It may not have a rhythm that is effective. It may not have the ability to move that blood forward. So that being said, there's always something atypical. And the elderly and women often have atypical signs and symptoms of an MI. But again, notice here that there's going to be a shortness of breath. Why? Because we're not getting the oxygen to the tissues, to the lung tissues. We're not getting the oxygen to the rest of the body to perfuse it. Weakness, nausea and vomiting, palpitations, fainting, falling, restlessness and anxiety. So if there's no reason, you have your mom that you're taking care of at home and she all of a sudden faints, and this is out of the blue, then you need to have her seen. It's not something that you prop her up and say, "You doing okay, Mom?" you got to recognize this is abnormal. This isn't common for her to happen. With women, again, you'll look at the different kind of signs and symptoms that they see. You're going to have that weakness and the vomiting and that type of thing. But a lot of times, women will think they have heartburn or gallbladder. It's more digestive. I don't know what it is, why they think that. But it's abnormal. So recognize, and this is one of the strategies you've got to use in taking your test questions. In the scenario, is the person old, elderly? Is it a female? Because some of those signs and symptoms there may give you a clue that you're looking at an MI or unstable angina. Don't just discount it. Oh, they're not having that problem. They're having a gallbladder attack just because it's a woman. Or just because it's, I don't know, just because. Just because. All right. So what is the emergent care for a person coming into the ER? And I need you to pay close attention to this because we're going to put time frames on here. And this is protocol. This is what everybody does with every patient that comes in complaining of chest pain. But we have to go through these steps to make sure that everything's covered so we can determine whether this is where they're having a cardiac arrest or if they're having an infarction or if they just have chronic stable angina, a narrowing of the arteries. And so the thing about this is that you will see in documentation from the nurse when the patient entered the doors and how long it took them to get the ECG on them, the leads on them. And you will see how long it takes them to go up to the cath lab or do other things. So we've got to look at this. So number one, the first thing that you do, what do we do when I say ABCs? Why is this an issue? They're having shortness of breath and ABCs. So if they're talking to you, you know their airway's okay. And they're conscious, so their airway should be okay, but they're breathing. What have we learned about breathing? Shortness of breath, where we're sucking air. We can't do it very long, exactly. We will start to decompensate pretty quickly. So what we're going to do is slap some oxygen on them. Slap it. There you go. And get the vital signs. The vital signs are going to tell us a lot, especially if you have a little old lady that's come in because she fainted. She was making Christmas cookies and she fainted. Vital signs are going to tell her, is this hypoperfusion? Because she doesn't have enough blood volume. Was that the reason she's fainting? Or could it be her heart itself? that is not getting enough blood to the body. We got to look at that. The vital signs tell us a lot. And then you're going to provide a continuous 12-lead ECG. And this has to be done within 20 to 30 minutes of the person walking in the door. So you go in, take their information, the nurse does the vital signs on them immediately. They take them further back to a bed. They slap some oxygen on them, and they're getting the ECG ready to put the leads on them. But it's got to be done. Those leads have got to be slapped on, and that 6 minute ECG needs to be read. Okay, you want to keep the sats above 95%, so you will titrate the oxygen as needed. A nurse will start the IV so there can be access unless you need to, in case you need to administer some medications IV intravenously. You're also going to give them an aspirin. Why do you think we're giving them a non-enteric aspirin? Usually it's 162 to 325 milligrams.
You want it to happen now.
Is what?
You want it to happen now and not to wait.
We want to happen to me. We want to get that aspirin in them pretty quick. So why though? That's right. So the platelets are not sticking together. And why do we want it non-enteric? Exactly. So it would be ineffective. We got to have it immediately in, and they need to be chewing on that aspirin pretty quickly. Okay, so we want to give nitroglycerin. Notice that the abbreviation for nitroglycerin is NTG. But we want to start that to see if it's effective. We want to give them morphine because that's the only kind of, it's not the only kind, but you need something that strong for the pain, to relieve the pain. Aspirin's not going to do it. We can't double dip with the aspirin. The aspirin's used for platelet adhesiveness and morphine's used for pain. And then we're going to start the lab work that we're going to talk about in just a minute, get a chest x-ray. And then we want to see if the patient is responding to these interventions that we're doing. I was going to tell a story and then I decided not to. It'll come up later, I promise. Okay, so in your textbook, there is a little mnemonic that they give there to help you remember. It's called MONA, because people that walk through the door are moaning. No, I'm just kidding. It stands for morphine, oxygen, nitroglycerin, and aspirin. These are 4 interventions you're going to do for a heart patient. Not necessarily in that order, but you will be giving those things. But they're not the only things you're doing either. So I don't know why it's in the textbook. To me, it's very ineffective. But that's just me. I haven't written one. Okay, so now let's go on to the ECG and tell us what we know with the ECG. So first of all, this is an essential diagnostic tool that tests patients with a possible or establishment of myocardial ischemia. Now, ischemia and injury, the same thing. Ischemia is the beginning of injury. When you're talking ischemia, there's something happening there that starts the inflammation process. So anytime you hear the word ischemia anywhere, whether it's the heart, whether it's something in the abdomen, brain, whatever, you can associate it with inflammation. And that is where you're going to see an inversion of the T wave. But the thing about it is that the changes that are taking place in the tissue of the heart are reversed or when the ischemia is resolved. Now, with injury, there is an elevation of the ST segment, which makes it a STEMI. So this is why a non-STEMI is less acute than a STEMI. Less problematic, let me just say that, than a STEMI. Because the ischemia has started, but there's no injury yet. But if ischemia is there long enough, then the tissue is going to be injured, and then there's going to be not complications, but problems with the cardiac muscle doing what it needs to do. And then infarction, on the other way, can cause death. Now, the thing about it is that when do we know that ischemia has turned into injury? Labs, thank you. Who said it? You say it's labs. Labs are going to let us know. So let's look at the different labs that we're looking at to determine what is happening. So first of all, an ECG is going to let us know if the injury has now infarcted. I said my C. I did. Not infarcted, but infarcted. And it's going to show those areas that are ischemic. Now, the thing about it is we laid those leads on that person, and how fast did we have to do the first ECG? And how fast are we going to continue? Is we going to do one and walk away? No, we're going to continue to run them. Exactly. So every 15 to 30 minutes, you're going to run another ECG and see if there's been any changes in the strip, which would indicate damages to the heart muscle itself. But the problem with an ECG is that it's only showing us what is happening in real time. It doesn't show us what's happened before or after, it doesn't predict what's going to happen next. My brother, who's older than I am, when he was 60, had all the chest pain and everything, couldn't get comfortable, went in to the emergency room. They ran an ECG, and the doctor said, hey, this looks fine. And my sister-in-law went into the bathroom to pee, and while she was in there, she heard a code and went out, and they were wheeling my brother up to the cath lab, and somebody was sitting on his chest doing compressions in the emergency room. That was like a 5-minute difference. ECG didn't show anything of great interest, and then he's on his way up to the cath lab because he's flatlined. So the thing, we can't predict what the heart is going to do. It's just telling us what's happening in real time. And we'll take the strip that happened 15 minutes ago and compare it with this strip and compare it with the next strip and the next strip to see what's going on. But the thing about cardiac markers or lab tests is that also is indicating what has happened. Now, the problem, we talk about troponins, and they're a group of proteins that are found in the skeletal and heart muscles. And they regulate muscular contraction. Troponin, yeah. So if you have this contraction going on and you get these levels, then we associate troponin levels or cardiac markers that are in the blood. We associate their level with whether or not a person has had an actual infarction. So when the heart muscle itself begins to get injured, then these troponins are released and they get into the bloodstream. Now, the thing about troponin levels is that it takes 3 to 4 hours for them, after an event, for them to become elevated in the blood. So a troponin level can't be detected for at least 3 to 4 hours in the blood. So when you're having a person that is having a non-STEMI event, now remember what's happening with the non-STEMI. We are there where we have, let's go back to our slide, where we have ischemia. They're having a non-STEMI. When they have injury, they're having a STEMI. So a person is having a non-STEMI. There hasn't been injury to the muscle yet. And so we were looking at the ECG. It's not showing any version or any ST elevation. So there's not been any injury to the cardiac muscle yet. And it's happened 1 or 2 hours ago, so there's no troponin levels in the blood yet. And so the doctor in the ER says, okay, you guys are fine. Just go on home and lay down and rest and don't do anything. But if it's into a progression, into a STEMI, where there becomes injury to the heart, the guy leaves the emergency room and has a heart attack 3 hours later and dies. This is why emergency room doctors are getting sued all the time, is because you can come in and do some of these diagnostic tests, but there's no indication really of what's going to happen or the extent of the damage or anything like that. We're doing the best that we can here to determine, has there been a heart attack here? Get it? You get it? So this is kind of a progressive thing. It tells us stuff. These diagnostic tests give us stuff real time, but we've got to look at the time factors that are involved here. And we have to recognize that it's no big deal if the doctor says, hey, we need to watch it overnight, see how you're doing. Because it can progress into a STEMI. Okay, so we talked about troponin, and it technically, where am I at? Okay, technically we've looked in on it, and the troponin is the gold standard as far as lab work is concerned. But again, the problem with it is that we can't get those lab values for 3 to 4 hours. But if we pull up the labs and there's troponin there, then we are 99% sure that they have cardiac muscle injury. Okay, it used to be back in the day that CKMB was a lab test to take to determine whether or not there's a person that's had a myocardial infarction. So if you have a heart attack, the injured heart muscle cells will release CKMB into the blood. Now, because many tissues contain CK, which is the first part of that little enzyme. High levels of CK can become a sign of a variety of issues. Now, higher values of CKMB can indicate cardiomuscle problems, but again, it's found in more tissues than the troponin is. And so that's why troponin is considered the gold standard, because it's much more specific to cardiac muscle. Now, another test that you'll look at that they might do is myoglobin. And myoglobin will rise before CK or troponin in the blood. And if you find it, it is 99% indicative of a MI. But it has to be drawn within 18 hours of the onset of pain. Now you say, well, why isn't that the gold standard? Because it has to be drawn within 18 hours. The issue is here that troponin will last for 7 days. So a person can come in 3 to 4 days after the onset. They've gone back and forth. They've rolled around in bed. You know, some people just don't like the doctor, so they'll avoid it, and go in 2 or 3 days later. And they're still having chest pain because that trauma to the cardiac muscle has stayed, and now there has been some infarction in the muscle tissue or in the cardiac muscle tissue. And so they're going in to get some relief, and they found out that 3 days ago they did, in fact, have a heart attack. So that's why it's become the gold standard.
Well, there's troponin, but there's injury or infection.
Injury. Okay, so the thing about it is that if the troponin, if the ECG indicates that the patient is having an ST elevation, they will be treated with the same drugs as a non-STEMI, but there are other procedures that they want to do to infuse or get that blood flowing again. This is where the coronary arteries have gone into the myocardial infarction stage, or where they are limiting the blood flow. It's beyond 60 to 70%. We are now almost stopping blood flow. How many of you have heard that when somebody goes in to have an angiogram, oh, she's 90% blocked? Well, that's 90% of the blood is not flowing through that artery that needs to be flowing there. So you're really to the point of cardiac death because it's not getting fed at all. So with the drugs, they'll do the non-STEMI, but they need to open up those vessels, those blood vessels, so that they'll start feeding the heart again. And they do that either by an angiogram where they go in and put in a stent. They call it reperfusion therapy. Or they will do it by doing a thrombolytic if it's because of a clot that has totally occluded the vessel. Or they'll do it by CABG, which is a coronary artery bypass graft. So let's look at this for just a minute and see what we're going to do to fix this. And these are called reperfusion therapy. So here's again, I found more diagrams than I can ever tell you about clotting or occluded arteries. But here we have the occluded arteries. You see it's very, very narrow. And what has happened here, there's 3 ways that we can do this. This is a thrombolytic agent that we're giving that person. And it can be streptokinase, it can be ATP, it can be TPA. These are different drugs that are used, but recognize them as thrombolytic. And they have to be given within a certain amount of time to be effective. So that's where they're going to go in, and you have this narrowed artery here, and then the blood is flowing through or slowed down or high pressured or whatever, it can go in there, but the plaque is building. A thrombus develops, totally including the vessel. So we've got to go in there and lyse that clot. And we do it by using those 3 medications that I mentioned, ATP, TPA, and streptokinase. And that has to be administered within a certain time frame as well. And they'll put that drug into an IV that'll go up and it'll just kind of dissolve that clot. Now that's different than heparin. Heparin is an anticoagulant. So heparin is used to prevent a thrombus from happening. But a thrombolytic is given to dissolve a clot that's already formed. And it has to be given in a certain amount of time. I believe it's 9 hours. But the thing about that is that will dissolve that and open up that lumen so blood begins to flow again. Notice that the middle of the clot is gone, but you still have this fat buildup as part of the arterial wall. So that's with the thrombolytic. Another reperfusion therapy you're going to have, if you have a STEMI and an infarction is imminent, is a balloon stent. It's like a stent. They'll thread this up your groin, or they're using the radial artery and follow the vasculature of a route and get into the arteries. Now, this is kind of scary. I don't know about you, but this kind of scares me a little bit. You know, that they are following up one blood vessel and they get down into the heart. So it's gone through the heart and then out the aorta and then into those arteries of the heart. Oh my gosh, how scary is that? But with that balloon, when they get to the point, they have this stent right here, or it's sometimes they call it a stylet, that they're guiding through the arteries of the patient, and then they get to the point where the lumen is very, very thin. And then they will blow up that balloon and stretch that fatty deposit here, push it back into the vessel wall. And then they will pull it back out again, and then blood will flow more freely. And now a stent, on the other hand, is where they go in and they put the stylet and they follow the vasculature up again to the point of occlusion. And the stent is a mesh type material that will go up against the vessel walls and keep it open. Now, the problems with stents are a little bit. The risk is there. For any of these procedures, the risk is there. So the problem with this is number one is that we leave the stent inside the vessel. And the stent is a foreign object. So do you think the body will react to this? Yes, it will react to this. It doesn't like it. Another problem we often have is that it's a foreign object, and so sometimes the stent itself has got anticoagulant and permeated into it, or antibiotics, or anything like that. But a problem with the stent sometimes is that the edge of it, the beginning of the end of it, will cut and injure the artery. But it works. Sometimes I had a student in clinicals once who preceptor was on the rapid infusion team, and they called from the cath lab that they needed the rapid infusion team in there immediately. And she went in there, and a stent was being placed in her patient, the student's patient, and something happened. The artery was nicked or something, and the patient bled out right there in the field, right there in the cath lab. And there was just, she said there was so much blood. There was just, it would splash as she walked in the cath lab. I mean, it very risky type things, but you are dealing with problems as well that can cause death. All right, so we saw thrombolytic. We don't need to know about that anymore. We've seen that. And then the balloon angioplasty we talked about. See how it's narrowed. Then you put the balloon in, and then it's all opened up and flows nicely. Those are just pictures to kind of help you visualize what's going on. Heparin, we talked about heparin, people that are prone to atrial fibrillation or something like that, where the atria is not contracting as it should, and so the blood is just kind of being it's just there, it's just moving, they're just juggling around. It will clot. You'll develop clots real fast. So a lot of times they'll be put on heparin to prevent clots. Okay, so let's talk about the management of a post-catheterization patient. Things are changing all the time. I can't believe some of the things that they are doing for these patients. But you need to recognize that wherever they have inserted that stylet to do this angioplasty, where they either put in a stent or they blow up a balloon, whatever, fact of the matter is you've entered an artery. Okay, so you are at huge risk of bleeding out. And it doesn't have to be inside it doesn't have to be all over the floor. It can be inside the body, you can bleed out. So you have to make sure that that artery seals back up again from that invasive procedure. And here's the thing too, is that if you are taking care of a person and you notice that there's a hematoma, it's not just a bruise, it's a hematoma. Then you know that the person is bleeding underneath the skin. And this is problematic. Because why? Because you're dealing with an artery. So you have to make sure that they are stable and that vessel closes up again and heals itself. And so it's critical that a patient be on bed rest for 6 hours. Now, it used to be that everything went up the groin. And so you'd have this sandbag on the groin, and they had to lay on the recovery bed in the cath lab for 8 hours, and they couldn't move or anything. Well, it's gone now. They've got these great little inventions like a surgical plug where they can, plug the artery and have a little bit of pressure in there. But basically, we don't want to stress those vessels at all for 6 hours. It's not as bad as it used to be, but it's still, you got to recognize you're dealing with an artery. So you want to keep the extremity, which was entered, whether it's going to be the radial artery or the femoral artery, you want to keep it straight. You don't want to be bending it, because that's going to slow down blood flow. We don't want to do that. We want to monitor vital signs. You want to look at the insertion site, because we got to make sure that it's not bleeding. And how do we know if it's bleeding? See blood? You see blood, or there's a hematoma developing underneath it. And you, where are you going to do a CMS check? This is an orthopedic surgery. Yeah, you want to make sure there's pulses distal to the side that the patient can move and have sensation. Yes.
So that more recently that they did away with this, when I used to work in CMA surgery, they would always do this. Like they have the sandbag, they'd have some more pressure.
But they, like I said, things are changing. It all depends. You follow your facility process, but the pressure of the sandbags are heavy. That's why they put a sandbag on there to put pressure. That femoral artery is one of the largest arteries in the body. They're not just accessing a little, superficial vein like they do with a peripheral IV. It's big. It's serious. Okay. All right, let's take a break and start this. Well, wait a minute. Yeah, let's go ahead and do this, and then we'll take a break. So cardiac rehab. So when the person has had a heart attack, or where they've had a STEMI, and there has been injury to the heart, or where they've had an infarction, where there's even been some death of cardiac tissue here, then we've got to recover from this. And this is a real interesting time for people, and I take a lot of these personal comments that I make in lecture from experience that I've seen others have, because I personally haven't had a heart attack yet. It's going to happen. I do have metabolic syndrome. So here's the rules, people. If you find my carcass in the office one day, you're supposed to start CPR, whether I am blue already and starting to decay, because otherwise it becomes a crime scene. And you guys can't come to school until they determine to kill me. But if you start CPR, then the paramedics come get me. They take it. They have to continue CPR until I get to the hospital and somebody declares me dead. Make sense? Why do I know this?
Sorry.
Because it happened in Oklahoma at the tech school that I taught there. Yeah. One of my colleagues went into the bathroom and came out and said, I think there's a dead man in the women's bathroom. And we'll never know why he was in the women's bathroom, but he was sitting in a stall, and when he had his attack, he fell forward. And we don't know how long he was there. And so we decided, should we do CPR? Yeah, we better do CPR. Otherwise, it's going to become a crime scene. We've got all these students in here that they'll have to interview. So kept CPR going until the paramedics took him away. And it wasn't our problem.
So so hypothetically speaking, if we found like a dead body somewhere, and you just started CPR and called the paramedics, would that no longer be?
No, if you found a dead body somewhere, probably they would call the police. But for me, I'm a part of this building, so I'm always here. There's no question why I was here or what I was doing here. So that's why you do the CPR. I keep my shirt closed, just for privacy's sake. Okay. All right. If I do rigor mortis, just kind of break the arms and straighten me out. Which happened the first time that my preceptor, to her in PICU, her first patient was a girl that had been in a car accident, and her family wanted to come see her, and they stayed, and they stayed, and they stayed, and she was in a sitting position, kind of a semi-Fowler's position while the parents were in there and the family was in there and everything else. And then it was time to take her to the morgue. And my preceptor said we couldn't get her to lie down. We couldn't get her to lie down at all. You gotta be careful about these things as a nurse. You gotta think about things in advance. I'm just saying. Okay, cardiac rehabilitation. There is this huge issue that happens after a cardiac event for people that are successfully live. If they die, then we don't have to talk about cardiac rehabilitation. But for people that survive a heart attack, there are a lot of physiological and psychological changes that occur in the body, and we have to address those as a nurse. So a lot of times, if somebody had a heart attack, they'd be in the hospital for 2 or 3 weeks. But now, because of insurance that's requiring shorter hospital stays, the sad thing is that a lot of times you will have this cardiac event, you'll go to the cath lab, you may stay a night, but then you go home. And so a lot of this stuff, this rehabilitation will occur beginning in the hospital stay and continue when you go home. So again, there's things that you have to address with the patient and the patient's family. So we want to start out with the goals of rehabilitation, and the goal, of course, is going to get them back to their highest level of functioning. Is this going to be what they were prior to the heart attack? No. But we can, but not everybody's going to get to that level. So, and it's going to be psychologically, it will make the patient very vulnerable because they recognize how close they came to death. They will recognize that they are going to die someday, and they will be extremely depressed at their inability to do some of the things that they did yesterday. It just psychologically, it just totally affects them, and they can become very depressed. So there are 3 parts to cardiac rehabilitation. First of all, when you do this is going to require a multidisciplinary approach to it, because you're going to have your cardiologist, you are going to have your physical therapist. Depending on the deficits that you occurred physically, you may end up with an occupational therapist, a speech therapist. You may require a pulmonologist. It's just vast that you are going to be dealing with so many doctors than you did yesterday. This isn't a slow transition. This is something that just came up on you. So the program is patient specific. In other words, it's developed by the multidisciplinary team and what they think is best for you and with you, according to what you are willing to do to recover. So there's 3 parts that are involved. There's exercise, and then there's the reduction of modifiable or non-modifiable risk factors. Modifiable, exactly. And then dealing with the stress and depression. So we're going to go quickly through this because I know you're ready for that. Okay, so first of all, phase 1 of the rehabilitation process starts in the hospital. The activities that are involved are determined by you, but I've got to tell you guys that if possible, they will get you up the first day of surgery. If you even have open heart surgery, if you ended up with a CABG instead of a stent placement, they have your heart opened at 10 o'clock in the morning, and 5 o'clock you come back from surgery, and 8 o'clock that night they have you sitting up. Movement is essential. But again, you do not want to exert the heart because that puts stress on the heart. And so we have to be very careful of the amount of activity we give these patients, but we do not want the complications of immobility to set in. So expect that your patient will be sitting up, if not walking to the chair or transferring to a chair to sit up on the first day of surgery or within 24 hours. Yes. Oh, thank you. I turned my page. Aren't you guys keeping up? Thank you so much. Okay, so recognize though that because this is the heart muscle that's injured, that we need to promote rest, but have an adequate amount of activity. We need to make sure that we assist them with their ADLs. Now, this contradicts what we learned before, is that we want to keep them as independent as possible, but recognize they are going to be fatigued. Their heart is not functioning as it used to. It has incurred some injury to it, and they just aren't going to have the strength or the oxygen requisite to meet the metabolic needs of the body, or what they did yesterday. They are going to have to go with what they can do, but at the same time, you're going to assist them to do that and offer as many rest periods during the day as they can. The patients will progress at their own rate until they can independently ambulate in the room or ambulate to the bathroom. And if you want them to walk out in the hallway, sometimes you'll have them go 50 feet, sometimes you'll go 100 feet, sometimes you'll walk them around the nurse's station, whatever they can happen. And then if with their activities of daily living, you may want to assist them, but encourage independence. And you can do that by offering a shower chair, because that heat from the water will vasodilate the person and they can get very, very weak. They can get very, very dizzy. So provide a shower chair for safety, but allow them privacy and independence of showering by themselves. So it's little things like that you can do to promote rehabilitation. The goal of a caregiver is to promote early ambulation and then introduce the goals of rehabilitation to the patient and enroll them in outpatient groups. Again, this is during phase 1. We want to develop an exercise prescription for them, and then we want to evaluate the response. If we say to them, okay, I want you to walk to the chair today, and they stand up, they may get dizzy. And so we got to reevaluate. Maybe that's too much for them. So tomorrow, let's have them dangle on the side of the bed, but at least they're sitting up on the side of the bed. But again, each individually. So we want to promote rest and ensure limited mobility as much as possible. Now, during these times of activity, you have got to be monitoring them and evaluating them frequently. And one of the ways that we do that is by taking frequent vital signs. So anytime you start them, get them ready to do activities, we take a set of vital signs. And then during the activity or right after the activity, for instance, if they sit up, we are going to take their blood pressure again. If the systolic blood pressure decreases by more than 20 milligrams of mercury, then we are going to reassess, have the activity not be so aggressive, and maybe the next day we'll have them do less, but still have them do something. But anytime there's a variation in blood pressure of 20 or more millimeters of mercury, then we need to stop the activity and then reassess with the physical therapist or the physician or whoever. Phase 2 begins 4 to 6 weeks after discharge. And this is where you're convalescing at home, and this is where the doctor is going to suggest that you start your exercising. And when we say exercise, we're not meaning go to the gym. Masa. It ain't going to happen. But this is where they start walking on a treadmill, or go outside and walking. And again, if they can't do a full mile, then do a half mile. If they can't do a half mile, then you have them go the length of the street. If they can't do the length of the street, you have them do the end of the driveway. We start at their level and then progress slowly. But we have got to recondition the heart. But why do you think that reconditioning the heart, that's not a good question. Let me think just a minute how I want to say this. The benefit of reconditioning the heart is that we are also keeping and maintaining condition of our skeletal muscles as well. Okay, and then phase 3 is going to be long-term conditioning, and that is where we are going to talk about modifying risk factors that can be changed and what we need to do to change them. And we're talking about diets, and we're talking about exercise programs, and we're talking about tobacco cessation if necessary. All those things that will contribute to the health status of the heart. It's recommended that the patient exercise 3 to 5 times a week, and that there should be a 5 to 10 minute warm-up phase and a cool-down phase. So 5 to 10 minutes is warm up, 20 minutes is the exercising, and then the 5 to 10 minutes is cool down. And the thing about it is that if we don't have that warm up period and if we don't have that cool down period, what is going to happen is we're going to risk further complications of the heart. Okay, you know what? I lied. I'm going to give this last little slide, and then we're going to take a break, and then we'll come back and talk heart failure. Okay, so coping enhancement following an MI. I got to tell you, people, I have never seen people get so depressed after they have a heart attack. It is just something that is very sobering to watch or to be a part of. Men that were very vibrant and active and do a lot of things, have come back and been very, very, they struggle with adaptation. And a lot of it is because there's a total loss of control. You want to go water skiing again, but you don't have the energy to walk to the end of the driveway. Clear thought, the brain needs an excessive amount of oxygen, but I've known chief financial officers that have made huge financial mistakes that have cost companies a lot of money because of a lack of clarity of thinking. There are just so many things that change, and it's such a sudden onset that there hasn't been any time to prepare for it. And so not only keeping the person physically important, we've got to get them to a mental state where they desire to rehabilitate and get up and moving again, because there is sometimes such a depression that is associated with this inability to be exactly like they were before, that heart patients oftentimes will listen to all the education and then go home and do nothing. And they become very sedentary, and they literally have a shorter lifespan than they otherwise would had they taken up their rehabilitation as outlined. So you do want to assist the patient to adapt to perceived stressors, because they're going to think that people aren't going to look at them the same. You want to appraise the patient's understanding of what has happened and what could potentially happen. You want to assure them. You want to encourage them. You want to help them to understand the disease process so that, and to be as optimistic about it as possible. You want to help the patient identify the information or the most immediate things that have to happen. You want to provide factual information and foster constructive outlets for anger and support the use of appropriate defense mechanisms. I got to tell you too that there's a lot of times there, because of the, if a heart attack has been a severe heart attack, and there's been oxygen deprivation to the brain, then some people's personalities totally change. And so they become very difficult to live with before. So this affects the entire family. So again, we want to provide them with support groups and remind them to come in for frequent visits to their cardiologist to make sure that they are living the highest level of functioning that they can. Okay, we're going to take a 10-minute break and come back at 5 to noon, and we will only have 25 minutes left. You think you're going home? No, it
Are
goes.
we not doing a lunch today? Just curious. Are we just going straight through? Because our sim starts at, or our practice, whatever thing starts at 12:30.
It does?
Yeah.
Who the hell makes these schedules? Okay, let's do this. You have your food right here?
We went 2:30 yesterday, but ours starts at 12:30.
Does it really?
Yeah.
That is so
We never
unfair.
checked that for
I don't know. I don't. All right, let me do this. Let me just go till noon, because we'll pick up heart failure more next Monday, okay? Because I want you to have 30 minutes before your sim. You'll need it. Oh, you'll need it. Okay, let's just keep going then. All right, because of that, I'm going to skip this case study for you, and we're going to go right into heart failure. Okay? So, heart failure. Let's start with the heart pump. We talked about that already. Have we not talked about this? Do you not know the flow of blood in the heart by now? Yes, you do. Okay, so the reason when we talk about heart failure, keep me abreast of the time, people. I'm going to go for 15 minutes, and then I'm stopping. That gives you 25 minutes. No, I'll go till noon. That will give you a whole 30 minutes. Okay, so heart failure is when your pump stops working. And as I mentioned earlier in the lecture, you know, with little kids, unless they have an anomaly, their little hearts just pump away, pump, 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 pump. And you're not going to have the problems that you see with older Americans that have, you know, not done well with maintaining their healthy lifestyles. And so you're going to find that if they have a heart attack for whatever reason, it's because of a lack of oxygen. They have respiratory issues. But with older people that have not done everything they should to maintain a healthy lifestyle, then the failing of the heart to effectively pump is going to be the result of things like coronary artery disease. We just talked about that, myocardial infarction, cardiomyopathy. What is that all about? Did she talk about that? No, it must be an RN semester thing because we don't talk about it now. But cardiomyopathy is where the left ventricle has worked so hard now, or has to work because of things like hypertension. Because when there's hypertension, we talked about that there's so much resistance that the vessels get smaller. They constrict there's a lot of pressure on the walls of the arteries. And because there's a lot of pressure here, then the heart has to pump harder to get the blood out into the aorta. Well, what happens with skeletal muscles when we go and work really hard, we look like Arnold Schwarzenegger. Our muscles just build and they look fabulous, don't they? Yes, well, they become manly men. But the thing about it is cardiac muscle is different. Yes, the walls begin to thicken, but what happens, because it's an enclosed system here, is that you have less room. As that wall thickens, you have less room in the chamber for blood. So not as much blood can get out into the system. And so you have decreased cardio output. So with cardiomyopathy, skeletal muscles become stronger. Cardiac muscle becomes weaker. It can't push as hard as it used to. And so you don't have the cardiac output that you had when it was in good condition. Substance abuse, we talked about cocaine, valvular disease, congenital defects, cardiac infections, inflammation, dysrhythmia, diabetes mellitus, hyperkinetic conditions such as hyperthyroidism and sepsis. And so what happens here is the heart just can't do it anymore. Just can't do it anymore, it stops. So when we talk about heart failure, what does heart failure mean? Heart failure is a clinical syndrome that occurs as a result of the inability of the ventricles to fill or pump enough blood to meet the body's oxygen demands and needs. Okay, so left-sided heart failure here. We talk about things in nursing school that are end stage or when a condition puts the patient in dire circumstances. But that's not always true. So a person can be in mild heart failure, which then can progress into moderate heart failure, and then into severe heart failure. So if the heart begins to fail, it can be progressive. We talked about some things that can contribute to that heart failure. We talked about hypertension being one of the major causes for heart failure, and that is because there's so much pressure in the arterial system behind that aortic valve that try to get the blood through that valve. The heart is the left ventricle is having to work really hard to get that out there. Now, we're going to learn about this in just a minute because we're going to follow this out. Okay, so here we go. This is where I start to draw. How am I going to make this work? What are we going to do?
That entire chalkboard is a whiteboard.
Let's put that down. Oh, that's not right.
Whoa.
I don't know. Tell me what they can see when I push this up. Is this?
Sorry, yeah.
Oh, you're kidding. Is that amazing? This whole time.
So you have to stop screen sharing and just have your
Oh, that's
webcam
right.
on.
Okay. I'm afraid to get out of this because I'm afraid that I'll lose the thing totally. Oh, that's not it either. All right, just follow me. Just follow my words. Draw it as we go. There you go. Draw as we go. So we'll end with this. When we're talking blood flow here, and we're talking about left-sided heart failure. There's right-sided heart failure. There's left-sided heart failure. So what is happening here? Where does the left side of the heart pump to? The blood goes from the left side of the heart where? To the aorta, to the body. So it's systemic. That's what we mean when we talk systemic. So and we just talked about hypertension being one of the major things that can cause left-sided heart failure because we're dealing with so much pressure going out there. But what are some other things that can cause left-sided heart failure besides hypertension? So what is feeding the left side of the heart? The lungs. It's coming from the lungs. So what can also cause left-sided heart failure? And when we're talking about decreased cardiac output, what besides a smaller left ventricle can cause less output going to body? I'm hearing it. What is pulmonary edema going to do to all those millions of little capillaries that surround the alveoli?
Increase surface area, and so it's going to decrease O2 exchange.
Exactly. Well, if there's fluid in the alveoli, which is what pulmonary congestion is, then the fluid's going up. Is it going to compress that capillary at all? Fills up, it's going to compress it. There's not going to be this diffusion of gases because of the fluid. So if they're compressing the capillary there, is there any blood flow going? Nope, there isn't. It's not going into the venous system. We're coming to the lungs from the right ventricle and going to the left ventricle. But if the capillaries are confused, there's going to be back up here and there's going to be back up here because or not back up, but there's going to be less blood filling the ventricle because of the compressed capillaries. Does that make sense? So then you're going to have decreased cardiac output. That makes sense? So when we're talking left-sided heart failure, we're talking about either pulmonary hypertension or we're talking about systemic hypertension. But we're talking about decreased cardiac output. Got it? So with right-sided heart failure, where is the blood coming in from? The body. Where is it flowing to? The lungs. And so let's say that we have pulmonary hypertension over here in the lungs again. And the blood is coming out of the right ventricle into the lungs, but we have hypertension there. So it's starting to back up. So the right side of the ventricle is not too small like the left ventricle. What is happening now is that the right side has an overfill of preload.
Every time you move your hand.
Oh,
Yeah.
look at me. More of me. I'll try to get out of this.
I have a word.
Okay. Oh, that didn't help. Okay. So let me go back for just a minute. I don't know where I am. Escape out of this. Escape. This is share. No, it doesn't. Escape. I don't know how to get out of this. Okay, I won't share anymore. Stop sharing. Stop sharing?
The little box on the bottom.
What boxes?
The bottom right, so that you have the blue, 3 that are blue on the bottom. You have the mic, the phone, and the camera. Go to the far right, the one that's not clicked yet. Cover over that.
I don't think that's one that we've done over and over again. Won't have. Just said, okay, I'm just talking.
There you go.